the Deep Dive with Altum. This is our monthly webinar series where we tackle the critical topics shaping healthcare finance today. Each month, we're joined by experts who help make sense of the obstacles and opportunities in our industry. Whether you're navigating complex challenges or looking to stay ahead in this rapidly evolving industry, the Deep Dive offers the perspectives and knowledge that you need. I'm Elizabeth Richards. I am the Chief Executive Officer of Altum, and I'll be your host today. So we're going to go ahead and dive in. This is our first deep dive of 2025, and we're thrilled to have Tyler Sanders, the Director of Patient Financial Services and Registration at St. Joseph's Candler Health System, with us today. Tyler brings 7 years of healthcare experience, with the past 4 years dedicated to revenue cycle operations. As the Director of Patient Financial Services and Registration at St. Joe's Candler, Tyler oversees critical functions including patient accounts, cash posting, compliance billing, customer service, self-pay collections, denials management, and patient registration. Collaborating closely with executive leadership, Tyler identifies opportunities to enhance payer strategies, maintain budget neutrality, implement initiatives to boost revenue and cash collections. Notably, he spearheaded a business office redesign, introducing improvements such as enhanced coordination of benefits and eligibility denial workflows, cash acceleration strategies, and streamlined insurance billing and follow-up processes. These efforts were projected to yield a $20 million in cash acceleration during the fiscal year. Before joining St. Joe's Candler in 2021, Tyler served as the Director of Utilization and Denials Management for UHS Behavioral Facilities in Savannah, Georgia. Today, we're going to dive in on the importance of staying ahead of regulatory and payer policy changes. Tyler, we are so glad that you're here. Tyler and I got a chance to chat yesterday and, just talk about, how so many of these changes and policies, if you're not staying on top of them, create massive impacts on the revenue cycle that sometimes people don't even realize. So Tyler, do you want to kind of start us off and talk about some of the things that we identified yesterday?
Yeah, sure. Hello, everyone, and thank you for having me, Altum and Elizabeth. Appreciate the time. So one topic, and one of the bigger ones our organization is tightening up our workflow on, and we've had success with against payers in the past. Our large claim audits, specifically payers targeting prepayment charge audits on their first remittance within that first 14-day period. So what we've seen a lot in our area is they've slowly incorporated payer policy changes. We have found them going back to 2019 when we went after our first payer in the denials trend that we found. So what many of them do, and has a significant impact on cash reimbursement, is they take a stop loss claim, whatever that contract is, and allows that payer to do a charge audit and exclude certain charges. So let's just say your stop loss amount is $100,000. We'll do $100,000 even. What they'll do is they'll go through, and they've implemented over their payer policies certain revenue codes that they can disallow those charges that they feel should not be included or included in the total charge amount in your reimbursement. So a $100,000 claim drops it, or $102,000 claim drops it to $80,000, and now you don't get the stop loss reimbursement. So when it hits your system, in the manner in which you track it, it causes a severe underpayment, and it affects finance department with your reserves and the amount that you're expecting. So we saw this with one specific payer, and we went after them. We chose to pursue legal action because we did not have anything specifically built in our contract to negate those. And we were successful in that first go around. So we have moved on to several other payers. These policy changes, though, they typically come in email form or fashion. I'm certain many of you have seen them, where you get a blast email communication with about 30 or 40 different links, and the payers deem those appropriate communication of these policy changes. They say we should be responsible for basically clicking every link under the reimbursement or payer policy changes and going through hundreds and hundreds of pages of these changes. So we've also already built in, after pursuing legal action, we chose that also building in contract and how we're informed of these changes are very specific, and that's helped us from a legal standpoint.
Yeah, that's always an adventure for hospitals, which most of them, without realizing, have agreed in their contracts to accept these notices either via email, via the portal, via snail mail that somehow goes into the, basement of the hospital and no one ever sees it again. Do you have somebody specifically on your staff that is in charge of trying to keep on top of that, or have you found a method or a manner that I know some facilities have a person who that is like their entire job is to try to stay on top of the payer changes?
So we do now within our managed care department. So we don't specifically in revenue cycle. I know myself and other directors, when we get these communications, we do I call it a decent scan of what we think and we need to read and see. After that first go around with a certain payer, we establish that within managed care though to ensure that we are tracking them as closely as possible. If it's not a full FTE, it's close. I'm not sure if they dedicated one full time, but it's close to it if not.
And then how does that communication work with it being in managed care and then you guys being in revenue cycle? How have you made, that's another issue that I see a lot of hospitals having a really, bad, or not bad, but a hard time getting the communication between managed care and the revenue cycle, or also the other thing is getting the managed care team to understand the impacts on the revenue cycle for things that seem like they aren't a big deal, like medical records requests is one that comes to mind. A lot of hospitals have been just covered up in medical records requests by these payers. And sometimes the managed care team is like, well, what's the big deal? We have to give them records. So how have you been able to kind of organize or optimize that communication between managed care and revenue cycle on these issues?
Great point. It definitely was an opportunity within our organization as well. I think they were kind of, as you alluded to, classically siloed, so to speak, many years ago. And I'd say over the last 18 months, what we've really done is just communication and education. So we'll bring data back. And a lot of times, our provider reps and our JOCs, everyone thinks rev cycle focus. Our managed care team's invited to see what issues we're having, whether it be denial related, policy issues, contractual issues. And that way they stay in the know. So our director of managed care, or my equivalent in the area, has been very vigilant about attending those and made it a priority, where in the past it was, oh, I'll jump on the call if I can. And that's really helped. It's gotten to the point where now, I know before 2 years ago in our organization, a contract would have been signed with a payer with minimal input from revenue cycle. That's just the way it was. Now I was in a contract last week where we have one coming up on March 1st that's for renewal, and we're not doing anything until myself and a few others review it. So we have designated touch points within revenue cycle to give feedback on what is acceptable to us and what is not. So it really started with communication and education. That's kind of how we tackled it. And so we have a better bridge there now. And that's what I would encourage a lot of organizations to do. And honestly, I think the more modern version, you'd have both under the same house. I really do. I know a lot of people don't like that idea, and it's a lot of responsibility for rev cycle leaders. But I think if you have that under one umbrella, you can have separate leadership. But I think they go so hand in hand. A variance tool, or whatever systems and technology you use to track your variances, depending on what EMR you're on. We're a Meditech expand shop, so sometimes we have to be creative. And how we do things. And so, some of our tech could be very beneficial for them, but they don't use it. So again, education, opportunity, and even training provided from the revenue cycle and data analytics team.
Yeah, I think that's another thing that's really important and conversations that I have with hospitals that are going through, new managed contract managed contracting processes is also like, what is your plan post the contract being signed? You know, what is your plan to make sure that, you know, you're running the data and the analytics to make sure that the payer is doing what they're supposed to be doing, and that someone in the organization is owning that, because just putting it in the contract is not enough. And that I also find makes some friction between managed care and revenue cycle, because, you know, they don't necessarily want to own that part of it after it's done. But there's, you know, that if somebody doesn't own it, then there's no need to even go through all of the back and forth to negotiate, because it's not useful for the hospital to even have the terms if you're not making sure that anybody's following up on them.
Yeah, no, absolutely. And we started it last February actually, and we've had about $4 million in cash acceleration from it. But we started a payer steering committee, is what we call it. And essentially, we flag accounts where normal collection efforts have not been enough. So we've received a denial, or just it was called a pure underpayment. They just didn't pay per contract, and we've either called to reprocess or done our appeal process and escalated to the provider rep, depending on that payer's method, and done everything we can from a rev cycle standpoint. So we've developed a flag system, and we report out on those each month. And in that committee is myself, our physician director, physician revenue cycle director for any of their issues, our VP of Rev Cycle, Marty Strand, CFO, Alan Butcher, and Director of Managed Care. And if there's legal action that needs to be taken, we invite our in-house counsel as needed. Say, hey, by the way, this is going to come, here's the data, those types of conversations. So that's been a really good work group, and it's very high level, very direct. We like to say there's a lot of money involved in those meetings, right? But it's really effective once we identify the accounts, and it empowers the team. Like, hey, you know, they take pride in the accounts that they work and the cash collections, and they have their own goals and incentives. So they get very frustrated when their age over 90 goes up, right? And so it incentivizes from, I say, the grassroots level all the way up.
That's awesome. So you guys do that monthly? That's great.
We do. We actually just had it yesterday.
That's awesome. Yeah. So I'm switching gears a little bit. When we talked yesterday, we talked about, you know, the Medicare wage index changes and how those, you know, so what we have the changes that occur because the payers put through different policies and such, or different contract language. And then we have the changes that occur because the government, you know, changes regulations or changes the Medicare, you know, wage index or things like that. So we've talked about how you kind of stay on top of what happens if there's policy changes with the payers, but how do you keep on top of regulatory changes that are going to significantly impact the organization?
No, yeah, that topic's a fun one, right? And it's not always sexy, is how I termed it to Elizabeth yesterday amongst us rev cycle people. However, you know, when an organization, so for anyone who doesn't know on the call, when Medicare typically does their wage index, it usually has been an increase over the last several years. And this is the first year that it actually wasn't. So when organizations budget, they budget for that increase and being able to have that reimbursement calculated for on your P&L. And so when the increase did not occur for over 200 organizations that were affected this year, it really hit the bottom line pretty good. So, you know, whatever that number is for your organization, it makes cash. And, you know, the theme of today is cash reimbursement from legal issues or policy changes. It really makes cash that much more important in staying ahead from a rev cycle, because you're going to, you know, CFO is going to look and say, hey, whatever you can do to get me the extra money, I need it this year, right? And the impact on our budget was significant. You know, we have very unique scenarios organization. We're a 340B hospital, an organization, and funding from that. So we have a lot of money that comes in, and that policy changes like Medicare wage index affecting your P&L that makes your rev cycle performance that much more.
So what was the impact of that Medicare of not getting that increase to St. Joe Scanner?
10
Or what
million.
is the projected 10 million? Yeah, so that's a big deal when you're not expecting that, and finding $10 million extra dollars is.
Absolutely. And in the intro, you alluded to the business office redesign. So luckily, you know, Alan, being a wonderful CFO and very knowledgeable, and worked at 3 health systems in Georgia now, he booked half of that acceleration, right? So he's like, okay, well, I'm going to count 10, and then anything else we get, that's just cherry on top, right? From a budget standpoint. And so luckily we're halfway through our fiscal year. So our organization, our fiscal year is June 30th. And so we were 12.5 ahead. So we've already met his budgeted goal. So if we
That's
meet
awesome.
our internal goal, we'll cover that. And we're going to meet it. So it does, but it adds the fun stress is what I like to call it. We're going to do our processes. We're going to trust them. We're going to enhance. We're going to stay on top of things and make things better where we can. So I always tell the team, I'm like, hey, we need to hit this internal goal now. And they're like, well, what's the rush now? We beat our budgeted goal. I'm like, yeah, but it's not about that. We want to be better and better and better.
So when it comes to things like this, like the Medicare wage index and the effect that had on an organization, who is kind of keeping an eye on that? Is that a you and Marty thing? Is the CFO doing it? I mean, how do you make sure you don't miss something like this that's going to have a substantial impact on the system until, you realize too late that you're down $10 million?
Yeah, no, good question. It's a combination of finance and then Marty and I from RevCycle. So we're very good about sharing different articles and changes that we see that come through, whether it be email. Believe it or not, we still get some in snail mail. And in Savannah, the mail goes through Jacksonville, so it just takes that much longer, believe me. So it allows us to be very communicate very well with one another. And when we go through month-end close process, the first 10 business days of the month, our one meeting, we bring up those topics. So when that occurred in the fall, when we found out that information, it was the number one topic. And then it was, okay, how do we readjust our budget for the rest of the year, right? How do we figure this out? And, Alan kind of looks at us and goes, hey, whatever you can do, bring it in, right? Whatever a little bit helps. And so I think, you have the director of finance or controller, VP of finance, depending on your organization, Marty, myself, and Alan directly, our CFO. You usually have that level, again, kind of like our payer steering committee. So we recognize and we escalate these significant financial impacts that you don't see in your daily rev cycle workflow necessarily.
So do you have like a certain, is there a specific resource that you guys work a lot with? Like, is it, I mean, there's Becker's, HFMA sends out things. Like, do you find there's something that's better than others to kind of keep on top of some of these changes?
For us, for anything Medicare, it comes from our MAC. So we stay on top of Palmetto website
Okay.
for us. It depends on where it comes from. National changes, Becker's is a very good resource. They do produce daily emails about those. And then also we have certain publications that we get. I can't remember them all the top of my head, but as many as I can sign up for, I do. But when it really comes to governmental changes like that, Palmetto is our go-to. Our government team stays on top of those. Of course, because if you don't see cash come in a day or something's delayed, remittances don't come back. So we stay on top of those there. And then we use various collection of resources. I wish there was one true source. It'd be fantastic, but.
Yeah. No, I mean, it's like, it just, as I'm sitting here, as we're having this conversation, it's just the overwhelming task of keeping up with not just the policy changes with the payers, as well as the regulatory changes. I mean, that in itself is enough for probably two people to have a full-time job all year on top of trying to run the revenue cycle. So, and then when you add in the fact that everybody's, in their own departments and they're looking at it from a certain angle, that's why I think what you said about having those monthly meetings is super, super important to get kind of everybody on the same page. So the kind of last thing that I wanted to address is we talked about yesterday about the payers pushing to go to percentage of Medicare charges in their contracting. And, that's obviously a very sticky situation because we don't know what's going to happen to Medicare charge rates over the next couple of years. So if you agree with a payer to go to percentage of Medicare charges, then that could be putting the hospital in a really serious position if and when Medicare has a large, a large cut. So can you talk a little bit about, what you're experiencing with that and how you're kind of approaching that right now?
Yeah, of course. So we're right in the middle of contract negotiations with a payer that wants us to go to essentially a percentage of Medicare, as Elizabeth alluded to, reimbursement. So OPPS, but a little bit more, right? And so this payer specifically has sent, their requirements several months ago and what those look like. And there's several red flags that revenue cycle industry should be aware of. One is the collection of data that these payers want. As y'all know, they're claim processors already. They're already using them. They're already using AI. All of this has been very well documented on the denial stand front. But what we also need to be careful of is what modifier data they're asking for. So in this circumstance, if I have a commercial or managed care, depending on how your organization looks at it, payer, and they, part of this new agreement and new payment and contract payment fee schedule, they want us to include, let's use POP and modifiers. And again, these aren't, and I've prefaced this, these aren't sexy topics, but they have significant impact on reimbursement. If we start reporting this data, our fear, at least our organization's take on it is, well, the next time they do a payer policy change in a year and or the next contract renewal, they're going to want to start reimbursing us at lower rates for those locations that fall under a certain modifier. And it can really, and Elizabeth, you just alluded to it, it can really, I mean, we're talking 60% cuts right there, right? And 40% cuts off reimbursement. And that's on top of anything that the government themselves and CMS regulates that they're going to do. So that's just the easiest choice in that contract negotiation. But there are several more examples that are very concerning. We have talked about within our organization, is it better to go to a percentage of charge, right? Like reimbursement, and you do it by service line, and then you negotiate that percentage of charge reimbursement across the board. We're really looking at creative ways compared to, I like to say, our traditional manner of contracting and APC rates and percentages. But rev cycle's role in that is very crucial. If we talked about the separation of church and state and siloed of managed care and rev cycle, but if you're not communicating and you're not educating that group on these types of concerns, they're going to think, oh, okay, well, we're okay. Nobody said anything, right? Or this is what we've always done, which we hate that term in our rev cycle. It doesn't fly. So it's a large concern. I know another provider health system we've seen it in Georgia already. They've already gone to it and they've expressed concerns to us about what they are going through, credentialing concerns, how they have to bill with those types of things on the claims. I know certain providers in Florida have seen it as well. So it's really about networking. Obviously, you keep your organization's personal and private confidential numbers to yourselves, but sharing concerns, and there are positives as well, and sharing those, what burdens you may have to take on and what may ease up.
Yeah, absolutely. It's interesting to me, the amount of time and effort and resources it takes to produce the financial impacts of some of these decisions or regulatory changes on the hospital, and really having to stay on top of and think 4 steps ahead. Like, I think that your position to be like, wait a minute, what are you going to do with these modifiers if we turn them over to you? Is that might seem like a very benign thing at the time, but to your point, what is that going to do to the organization in 4 or 5 years, or what are they going to try to use to bring that up? I'm gonna hit you with something that we didn't talk about, but I feel like you're gonna have it. It's come up a lot. I've been speaking on it a lot. The use of the payers' use of AI in processing and denying claims. Have you been successful in any of your recent contract negotiations and putting some stopgaps in place on the AI, or how are you? Because in my opinion, in addition to the policy and the regulatory changes, the AI and the way that the payers are using the AI is probably the other thing that is most affecting the revenue cycle, the financial impact on these situations, and trying to stay on top of what they're doing and where they're doing it and how they're doing it is also a super difficult task right now.
Yeah, so we've been quite fortunate on the timing of AI, I will say. So this is our first contract negotiation, and we have several more over the next year. So this is our first one, and we are including language to help mitigate that. We take really good pride in our denials management program, and we have a lot of reporting around the analytics and different types of denial subtypes, card combinations all the way down. And we mitigate those where we can with bots and that type of movement as well. So humans don't have to touch it to counter the payer AI. But I would say one thing, and it's a twist off of them using the AI to deny the claims as well. And it kind of ties back to our last subject as well with payer policy changes is, and it's something I've asked vendors to think about as well is, okay, well, can you have AI, if I can't develop it in my organization, can we have an AI tool that goes out and reads these things for me and compares them to our contract? Because that would save a ton of time. Now it's a big ask, but the way that we're going, I really think that, I like to say claims processors, to your point, Elizabeth, they put in the AI right behind the claim processor. So they say, okay, well, this claim's probably good to pay from what I've learned. However, we're going to ask them for records just because, or we're going to ask for the IB just because, right? And it's more of like a second stopgap. And a lot of them, because, and no one, again, this isn't directly impact workflow, but a lot of it comes down to their quarterly stock prices, right? And you'll notice the trends, and we've talked about it within our organization. You'll notice at the end of the year, whenever they want their numbers to look good going into 2025, for example, you'll notice a spike. You'll notice a spike around quarter two after the first half of the year where they've come out, our numbers are great. Well, let's, cause a little bit delay and then pay everybody back out the third quarter, right? And then do the same thing. And it's cyclical. But that's kind of how we've started to deal with it. We're again in the early stages of it. But we are very well aware, and what we're really seeing what works with this first payer and what they'll allow us to get language in. They happen to be our second biggest payer, so it's a very good test for us.
Awesome. Well, I just wanted to ask really quickly before we end, is there anybody in the audience that had any questions that they wanted to put in the chat or comments? All right, well, awesome. Well, so lightning round, Tyler, like what do you think, biggest thing, we've talked about a lot of stuff, but like biggest thing going into 2025 that's going to impact, revenue cycle and the bottom line, if you had to choose one or two things, what would you choose?
Beef up your revenue integrity areas. Anything that has to do with modifier, charges, non-covered, and those types of changes, be very wary of those areas. Denials has been a really hot topic the last 3, 4, 5 years, and it will continue to be. But what gets missed is non-covered charges for XYZ reason. And you have to figure out as providers, is that contractual? Is that by policy? Is that because they're just not paying and they're just seeing what they can get away with from an underpayment? They'll figure out your threshold of underpayments that you won't work, right? So be very wary of that area and make sure that you address it.
Yeah, absolutely. No, I agree that, it's much easier to track and see the full denials, but the line item charges are where you really can have an impact that's not realized if somebody's not watching that.
Absolutely.
So. Awesome. Well, thank you guys for attending the first deep dive of Altum of 2025. Tyler, thank you for giving us 30 minutes of your time and sharing your expertise with this group. We really appreciate it. And stay tuned to the Altum LinkedIn and Instagram pages for information on our February deep dive. I hope everyone has a wonderful holiday weekend. And if you're in the Southeast, stay warm. Well, probably all over the United States, but we're extra cold in the Southeast right now. So have a great day. Thanks, Tyler.
Thank you, everyone.
Bye.